The New England Journal of Medicine, Racial Disparities in Medical Care. Many studies have shown that Black Americans are less likely than whites to receive a wide range of medical services, including potentially life-saving surgical procedures. Despite this data, which spanned 2 decades, there is little evidence that racial disparities in medical care or in measures of health have substantially diminished. Black Americans have an average life expectancy that is 6 years shorter than that of white Americans. And there has been little change in this disparity during the past 30 years. Why has the evidence on racial disparities failed to galvanize a response within the medical community? 4 factors have contributed to a slow pace of change. First, much of the evidence has been based on administrative data, leading some clinicians to believe that the racial disparities reflect unmeasured differences in clinical or socioeconomic factors. Second, clinicians may believe that whites are more likely than blacks to prefer intensive medical treatment or surgical therapy. Indeed, such research has suggested that there are such differences in preferences according to race. Although the differences are small, the outcomes that may be directly probably cannot explain the large racial differences in treatment. Third, few studies have evaluated differences in clinical outcomes that may be directly related to disparities in the use of medical services. They go on to say that the percentages are different, and they don't change based on the race of the doctor. If the doctor is white patients get more treatment, and they need stents or catheterizations or any kind of medical procedures. They get them at a higher rate than the black patients do, and it doesn't matter if the doctor is black or white. That's because they've trained the black doctors to treat the black patients just like the white doctor does. The racism is systemic. Despite the uncertainties, racial disparities in medical care are particularly troubling for at least 2 reasons. The probability that they reflect discrimination or racial bias on the part of physicians and their potential deleterious effects in health outcomes. The article by Chen and others in this issue of the journal provides information relative to both of these points and represents an advance in our understanding of racial disparities in medical care. Approximately 40,000 Medicare beneficiaries who were hospitalized in 1994 and 1995 with acute myocardial infarctions, they've had heart attacks, were followed to assess whether they had undergone cardiac catheterization within 60 days after a hospital administration and determine their rates of death during and ensuing the 3 years. As I said, white patients were catheterized at a rate of 45.7% for white patients versus 38.4% for black patients, regardless of whether the doctor was black or white. Racial bias is difficult to detect in surveys of physicians or medical records. Physicians may have various biases, but they often do not perceive them and would not report them as such. Let me read that again. Racial bias is difficult to detect in surveys of physicians or medical records. Physicians may have various biases, but they often do not perceive them, and they would not report them as such. Let me tell you something. They perceive them. They know damn well they're there, but they won't report them. They'll lie about them. Thus, it is no surprise that previous studies have not directly documented bias. Instead, racial bias has always remained a possible explanation for residual racial differences in treatment, and other explanatory factors have been accounted for. That comes to that around that whole notion of reasonable and proving discrimination. The proof is in the pudding. Proof of the pudding is in the eating. I mean, you see the results. People want treatment. People want good treatment. Doctors prescribe less around diagnosis, treatment, and prescriptive care when it comes to black people, minority patients. A recent article suggested that black children are given less pain medications in hospitals than white children. It goes on to say, of course, even if, as the findings of Chen and others suggest, overt racial bias is unlikely to be a major explanation for differences in the rates of cardiac catheterization, both white and black physicians may have subtle biases that are based on other social factors that influence their judgments about patients' suitability for procedures. For example, previous research has documented difficulties in communication about cardiac testing between physicians and patients of lower socioeconomic status. And physicians report personal perceptions of less affluent or less well-educated patients that are more negative than their expectations of other patients. Black patients are disproportionately represented in those socioeconomic groups, the lower socioeconomic groups. They're talking about people who do not speak up for themselves, people who are afraid of doctors, who go along with anything they say. If they're served less, they get less. Even when you have affluent or people that are educated about what's going on with them and what their needs are, white doctors are not comfortable with that. They look at you sideways. They're going to give you biased, racialized, racist care. And you have to press them to get the best. And then that's a scary thought. I mean, if they have to do a surgical procedure on you and you push them for, you want to do this, you have the insurance. If you don't have the insurance, you want the best treatment you can get. The state at least should provide that. This goes on to say that Chen and his colleagues also report the adjusted mortality rates over a 3-year period to black patients were lower than those or equivalent to those in white patients. The study, however, was unable to assess whether blacks underwent fewer necessary or appropriate procedures that were likely to improve outcomes than whites. In a study based on detailed clinical data from an academic medical center, the rate of underuse of coronary artery bypass surgery was much greater among black patients than among white patients, for whom these procedures were projected to prolong survival by 1 year or more. Differences in treatment according to race explained about half of the actual difference between blacks and whites in their adjusted 5-year mortality rate. This study and others have assessed the appropriate use of important medical procedures known to improve outcomes are that the measured rates of use of several basic processes of care related to survival, such as physical examination and diagnostic testing, provide a compelling rationale for eliminating racial disparities in medical care that have important health consequences. Given the widely documented pattern of racial differences in health care and some evidence about their causes and clinical effects, what steps should be taken to address these differences? Measuring differences in treatment, according to race remains an important endeavor. Documentation that blacks receive fewer services than whites may not be novel, but it's still necessary to gauge the effect of interventions to reduce racial disparities and to monitor whether the disparities are diminishing. They aren't. We should also continue to clarify the clinical effects of racial disparities. Unless differences in medical care according to race reflect the quality of care and meaningfully affect patients' survival of quality of life, the existence of racial disparities will remain of far greater interest to social scientists than to policymakers and physicians. So this, in essence, becomes like that's not the word I'm looking for. something that's more research oriented than it is about whether the medical community is going to wake up, smell the coffee, tell the truth, and do the right thing. When the OJ say they're out to get you, and I ain't lying, it's true. It's across the board. It's systemic. It's endemic. It's epidemic, and it's chronic. You cannot tell them that is all the stuff. They don't want to hear it, and it scares me to think about people who are less knowledgeable and less forceful about what's going on with them and the outcomes, and they can't speak up. And so the doctor just like slides them along, gives them less, and they end up with shorter life expectancy and difficulty during the short life expectancy. I mean, they have more problems. They're sicker. They don't get the kind of support they need around even the physical as well as the mental health issues related to having physical or mental health issues. So we have a double barrel problem. We're getting it from whites, and we're getting it from black people that are being taught by whites. So if you as a group, you're taught something by a group of people that have an interest in your demise. They don't really give a shit about you. Like Michael said, they don't care about us. And you go to their school and you learn every damn thing you can learn. You come out better than them. But you're so trained and orientated toward the system that you treat your own people just like they do treat your people. That you're part of the problem. Martin Luther King should be rolling over in his damn grave for dying, for people to get the opportunity to be trained in any field, including medicine, and come out of the game and help maintain the same damn system. That's some of the dumbest shit to ever hit the universe. And sleeping, educated fools from uneducated schools, as Curtis Mayfield said in his song. And he said, if there's hell below, we're all going to go. But I don't think hell is a place that's shared between the oppressor and the oppressed. If there's a hell, it exists for the oppressed. There's nowhere the oppressor, there's hell, it exists for the oppressor. There is no way an oppressed people should go to anything called hell. They're experiencing the hell from the oppressor in the existence that they're living from day to day. So if there's anything beyond this, it has to be something better or some type of blessing for the oppressed. Like Peter Tosh says, down pressure man, who you going to run to? When the rocks start melting and the ocean starts boiling, who you going to run to? We will see.